AETCM, the Emergency Medicine channel. So today we are in a team of ER physician and ER technical nurse. So we have Dr. Katyani, myself Dr. Arun Kumar, I'm the assistant professor in the emergency department, and we have Sumaya, our EMT technician. So what we will be trying to demonstrate today is it's a pediatric pre-cardiac arrest and a cardiac arrest scenario. So before starting into that sort of presentation, I would like to inform pediatric generation of people are never to be treated as adults. Why? Because we will be demonstrating like that. Now, the important cause of cardiac arrest in pediatrics is always hypoxia. The second cause is hypotension, and third cause could be hypoglycemia or anything related to the 5H and 5Ts. In fact, hypoglycemia is definitely a cause only in pediatrics and not in sort of adults. Now, in this case, what we'll try to do is we'll try to run a scenario in which a child is entering the ER in a pre-cardiac arrest scenario, and then we'll try to resuscitate the child, and during the course of treatment the child ends up having a cardiac arrest, and we'll see how we are going to resuscitate the child. Okay, so we have this 1-year-old child who had come to the ER in an obtunded state since around 6 hours. Now this is a 10 kg child and the mother is telling us a history. Okay, we have Dr. Katyani taking the history, and we'll try to demonstrate when a child come to the ER, how will you assess the child and followed by resuscitation also. Over to Dr. Katyani.
Whenever a child is coming, we will have to start the assessment with the pediatric assessment triangle.
Exactly.
To rule out any life-threatening causes there.
Yes.
So the pediatric assessment triangle, we have 3 limbs: the appearance, the breathing, and the color or the circulation part.
Yes.
So in appearance, we will be checking for the tickles, as the mnemonic is tickles, which we will look for the tone, the interaction of the child, consolability, look, and speech. So sir, in this child, what was the appearance?
Appearance wise, the child is very sick looking, as I told earlier, obtunded, and the child is not responding to your verbal commands of your or neither the mom's. And the child, when you look at the child, the appearance as such, the child is looking very dry in fact, and the skin looks to be really dry, mottled. And anything else you have to assess in this child?
Being in an obtunded state, yes, we'll have to, as any case, we'll have to check for the central pulse.
Okay. The central pulse is very feebly felt.
And we'll also have to check for hypoglycemia, which may be the cause of the reduced response in the child.
Okay. So could you please interact with Sumaya to have a look at the GRBS?
Can you just check for the GRBS in the child, capillary?
Okay. GRBS. The capillary blood glucose, which is revealing, is 30. So
in an infant, 30 means child is in hypoglycemia. So
okay,
we'll have to correct the hypoglycemia. For that, we'll require a IV access. In this 10 kg child, we can go for either a 24 size cannula or a 26 size cannula.
Okay. Can you just tell me the color coding of that sort of 24 and 26?
24 size cannula is a yellow color coded, and okay, 26 is a purple color coded.
Okay.
So since the child is also very dry, mottled and all, child is also having a dehydration component, yes, which we'll have to look for.
Yes.
So 2 things we have to correct here. One is the dehydration, the hypovolemic status. Second is the hypoglycemia. Okay. So hypoglycemia, we'll have to correct by 10% dextrose in children. So we can give 5 ml per kg, that is 50 ml of 10% dextrose to this child as a bolus dose. Okay. And the hypovolemia or the dehydration part, we'll have to correct it by 20 ml per kg bolus of normal saline. That is 200 ml of normal saline as a bolus dose over 5 to 10 minutes we can give.
Yes, in fact very true. So this is what I was mentioning earlier. There's a significant difference between how you assess a child from an adult. So as Dr. Katyani said earlier, we have to start right from pediatric assessment triangle. Now this is a miniature version of what we start as A, B, C. Now to this part, what is more important is the pediatric people, the appearance of the child carries a lot of importance, because that is how we figured okay, the child could be severely dehydrated, and the child could be having some sort of other injuries which is more of intracranial system involved also, because the child is obtunded, so we never know. Now first we ruled out metabolic arrest. In fact, the child had hypoglycemia, and child currently has signs of severe dehydration also. Now there is one more adjunct to be used when in terms of child being obtunded. She said something about random blood sugar or capital blood glucose. So apart from that, do we need any more adjunct to be in this child?
We can go for a venous blood gas analysis, or a arterial blood gas, preferably a blood gas analysis required. It will give us an idea about the metabolic acid-based derangement, anything is there, and also we will get an idea about the electrolyte status in our blood gas. So whether there is any hypokalemia or hyperkalemia or any other electrolyte abnormalities, and also we will get an idea about the hemoglobin status, everything from the blood gas.
So in fact, this child had a pH of 6.9 and a bicarb of say like around 10 with a lactate of 10 and PCO2 like somewhere around 30. So how do you interpret this ABG?
So this is a metabolic acidosis. The ABG is a metabolic acidosis, that is a lactic acidosis.
Lactic acidosis.
So the lactic acidosis, here the cause mostly can be a dehydration leading to hypotension, because the child had the physical like signs of dehydration.
Signs of severe dehydration. Now one thing, the clause to be ruled out in this case is, now we don't know the patient is having any sort of cardiac dysfunction. As we told earlier, there is a definite indication of giving fluid bolus in this child. So definitely we have to rule out other cardiac causes also before giving IV fluids. But then in this child, as Dr. Katyani mentioned, there are signs of severe dehydration which can end up the patient going for a cardiac arrest possibly. So we have to rush in fluids. So 20 ml per kg is the IV fluid bolus dose which is supposed to be used here, and we can use how much? 200 ml bolus can be given this child.
200 ml bolus we can give. We can reassess the child. If at all required, we can go for 2 more balls. It's total like 3 balls of fluid we can give to the child.
Okay. So currently you have come to the appearance, just the appearance of the child. Just because the child was sick looking and toxic looking and child was more into an obtunded state, we have corrected the hypoglycemia part and we have given the first shot of IV fluid bolus. And now we have to reassess the child. So reassessing child, how are you getting this? The child, if the child is moving or not?
The child still remains to be like in a low mental sensorium state.
Okay, the child continued in that sort of deteriorated state. So what's the next plan of action to be done for this child?
Again,
the child is definitely still in the dehydration, severe dehydration part.
So we can again give a bolus of fluid. We can assess for simultaneously we can look for the breathing component of the child.
So initially the patient had, as I mentioned earlier, the child had a very feeble pulse. So pulse rate was somewhere around like 86. So currently, while you give the second bolus of IV fluid, the child pulse rate dropped down from 86 to like 54.
Less than 60 in a child, we have to check for the pulse. If not there, we'll have to take it as a cardiac arrest.
We have to take it as a cardiac arrest. Okay. So you have to page code blue or resuscitation team, isn't it?
Yes.
Okay.
Fine. So here, what we'll have to do is we'll have to start on the CPR, like any other cardiac arrest.
Yes.
So CPR.
Do we have a team for CPR?
Yeah.
Giving CPR.
Sumaya will take care of the CPR.
Fine.
So in a child, like a 1-year-old child, we can either go for the 2-finger method or the thumb encircling method of CPR.
Okay. Suppose Sumaya is not there. So what will you do then?
I'll take care of the CPR.
Fine. Start the CPR.
So here I'll be going for a thumb encircling method. So the rate will be like for 30 compressions, we will give 2 breaths.
Okay. Please count it aloud.
1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11.
Okay. Now your team has approached. So you will take care of the airway and you will start the CPR, isn't it?
Yeah. So I'll keep the child, I'll be at the head
end.
Then.
Yeah. So one person should be on the foot and who will be giving the CPR, and the person on the head then will take care of the airway. Okay.
And we have the pediatric ambu
So
bag.
one more thing to be asked is, what's the difference between volume in the pediatric ambu bag from the adult ambu bag?
So this is the volume here is like around 450 to
approximately like around 350 to 450 ml, and what the normal adult airway is somewhere, ambu bag is somewhere around 750 ml, isn't it? Okay.
So and the mask size also we have to look for it. It's like a smaller size of mask we use for the pediatric.
The thing to be remembered is the mask should be covering the entire oral airway followed by the bridge of the nose, and the seal should be very apt, because one of the most common mistakes how we select the mask is it could be either very small or it could be even very big. The problem is one is air leak and other is causing much more discomfort and you're not getting the adequate tidal volume to be achieved. Yes.
So here we have a proper mask seal and 30:2 compression rate.
Yes.
We can.
Please start compression, Sumaya.
1, 2, 3, 4, 5, 6,
Yeah, please tell me the characteristic feature of giving an adequate CPR.
Like CPR, it should be push hard and fast.
Okay.
Then like there should be adequate recoil.
Yes.
The depression should be like around 1/3 of the AP diameter.
Okay.
Then the interruption should be less than like 10 seconds for changing the CPR and all. The interruption should be less.
Okay. What is the rate?
We can give 100 to 120 per compressions per minute.
Per minute. Okay, fine. So now you have started the compressions, you have started the amboving. So what is next to be done?
So we'll
you already have IV cannula also.
Yeah, we'll have to connect the patient to cardiac monitor.
Excellent.
And we'll have to give after assessing the rhythm whether shockable or non-shockable, we'll have to further.
Yes. So in the difference between out of hospital cardiac arrest and in hospital cardiac arrest is the cardiac monitoring connection should be as early as possible. Why? Because we never know, it could be probably a defibrillation to be done as early as possible. It could be a shockable rhythm, isn't it? So in this part, the patient was assessed during the course of stay in the hospital or in the ER. During the treatment analysis, the patient went for a cardiac arrest, and now we are figuring out what could be the possible cause. In fact, we have already 2 causes, and in fact we have already corrected 1 cause. So we have 1 more cause, so that is severe dehydration, possibly going for severe hypotension. Yes, and now we are giving IV fluids, we have given CPR. What's the drug to be given now?
So we'll have to go for IV epinephrine. So the epinephrine, the dose is 0.01 mg per kg. That is, we can give in this child 0.1 mg. That is 1 ml of 1 in 10,000 dilution of IV epinephrine should be given.
Crisp. Okay, great.
And we have to continue the CPR. Epinephrine should be given every 3 to 5 minutes, and we'll have to assess the rhythm every 2 minutes.
Okay.
And by the time we already have got the ABG, so the causes of cardiac arrest, the 5Hs and 5Ts, we have to keep in mind.
Yes.
So here we have, as sir already told, we have the hypoglycemia, we have the metabolic acidosis, and there was no hypokalemia or hyperkalemia or any electrolyte abnormality.
Yes.
Then we have to look for hypoxia was not definitely there, but we are managing it with the bag mask ventilation.
Yes.
So that is
the most important thing to be remembered is there is no hypoxia. So you can ask us why the child is to be intubated. Yes, it is not the primary indication to intubate the child, but remember that altered mental status secondary to dehydration is definite indication for intubating the child if the child is not recovering after adequate fluid resuscitation. Now that's the statement to be underlined, because if the child is not intubated, possibly after some time the child will eventually develop some sort of respiratory component, maybe developing respiratory acidosis. So it is always safe to intubate once the resuscitation part has been covered entirely. So we will reassess the child, we will see how the patient is responding. Will look up to the mental state of the child. If the child continue to have altered mental status, or probably continue to be in the same mental status as before, yes, the child to be intubated.
So while the resuscitation was going on, we assessed the rhythm. It was asystole was there, so we continued with the IV epinephrine and the compressions.
Okay.
And after the resuscitation part is there, we can go for the intubation or the definitive airway.
Yes.
So
basically, have you given compressions and have you given the adrenaline part? Yes. Okay. So the dose has been. So there is one more thing to clarify. There is something called as an intravenous drug dose and intratracheal drug dose. We haven't intubated the child yet. Yes. So what's the difference between intratracheal and intravenous dose?
In a pediatric age group, it is 10 times the IV dose is given for adrenaline via the ET tube. So here we already had a IV line, so that is the preferred
Yes.
method of giving the drug. But if we don't have IV line and we are not getting a IO access also, we can go for a giving the drugs through the ET tube.
Yes. So what's the dilution difference factor in the intratracheal dose?
So 10 times means we can give 1 in 1000 dilutions, the same dose 1 in 1000 dilution. That is 1 ml of 1 in 1000 dilution of adrenaline can be given for a 10 kg child. Okay. That is, we can give it through the ET tube followed by a 5 ml of NS we can give, and give 5 breaths should be given. Okay. That is ideally how we give a drug via the ET tube.
Okay. So after 4 cycles of CPR, it seems that the patient has got a rhythm. Okay. Okay. Now where do you check the pulse in this child?
Here we can check for the central pulses, check the brachial pulse can be checked.
Yes. Where do you check the brachial pulse? Illustrate where do you check the brachial pulse?
So it is in the cubital fossa, on the medial side, we'll have to check for the brachial pulse.
Okay, fine. Great. Okay. Fine. So you have checked the brachial pulse. You're getting an adequate pulse. So yes. And then what is next? Now you want to take a repeat sugars.
Yeah, like it has been like over a period of like 20 to 30 minutes. So
Yes.
we had initially corrected the hypoglycemia. So we want to rule out.
You want to check a repeat random blood sugar. Okay. Currently the sugar is 78. Are you happy with it?
It is fine because we have a ongoing DNS 10% dextrose is there.
Yes.
So it is like acceptable range.
Okay. So do you want to repeat ABG for this child?
Yeah, once the resuscitation part is done and we have got the ET tube in situ and all, after like about 5 to 10 minutes we can go for a repeat ABG.
ABG. So current ABG is looking like a pH of 7.01 and with a PCO to somewhere around 32 and with the bicarb somewhere around 12.
And lactate?
Lactate has dropped down from 10 to like 6.
Okay. So
this is ABG which has been taken 45 minutes from the arrival of the patient.
Fine. So like compared to the earlier ABG, the metabolic status has improved a bit, and the lactate is also clearing. So probably the hypotension part has been improved with our dehydration has improved with our fluid resuscitation.
Okay.
So like we can take it mostly the cause of the arrest will be the hypovolemia or the dehydration.
Possibly.
So
at this junction, you are coming back to the patient because the patient has continued to be in the same mental status, isn't it? So what to be done next?
We have corrected GRBS, we have corrected the fluid, we have secured the airway.
We haven't secured the airway.
Like now we'll have to secure the airway because persistent low mental status, we'll have to secure the airway.
Now we have two definitive indications. One is, as she told, persistent decrease or deterioration of mental status, and second is patient continue to have severe metabolic acidosis. Isn't that true? So we are supposed to secure airway, isn't it? Yes. So we will go with an airway. Now tell me like briefly like how do you intubate this child?
While preparing for the intubation, we'll have to check have the pediatric ambu bag and all those things. Then we'll have the ET tube. ET tube size for this kid will be 3.5 cuff tube for a 10 kg child.
Okay.
The laryngoscope will be a straight blade or a Miller's blade, that one size Miller blade we want.
Yes.
Then we want the other ETCO2 monitors.
Yeah, you need to connect to the cardiac
monitor, everything like that the child is on.
What are the drugs which are used for this intubation of the child?
For this child, we can give etomidate and paralytic of rocuronium, post cardiac arrest. But if the child is responding, we have to give a sedative and paralytic to reduce the ICP increase and all.
Yes. So suppose this child is not responding. So would you use drugs then, or would you take it as a crash intubation? Because crash intubation, we never use all these drugs, isn't it? So the patient is used, as you said earlier, the patient GCS continue to deteriorate, but it remained the same all throughout the stay in the hospital. So do you still use drugs?
If it is a crash intubation, we don't go for
it. In fact, this is a crash intubation, isn't it?
Yeah, post arrest, if the child is still like
after
very low,
reassessment
still low, we will go for a crash
the child
intubation.
Continue to be on the lower side. So do we need drugs?
Ideally no, like because already the child is having like low sensorium, sedation is not required.
The child is not taking a trigger adequately, isn't it? So in this case, we should take it as a crash intubation. Now that's a difference. Now in this case, like we don't have to give the drugs because already the entire reflexes of the child has completely been obtended. So it's been completely blunted. So you don't have to use another set of drugs. So in fact, you can go for a crash intubation in this person. Okay.
So crash, since it's a crash intubation, after oxygenation is ongoing. Yes. So we can scope the child, and for positioning the child, we can
use. That's very important.
We can use a bed sheet or a towel bag in between the scapular blades. We can keep it, and the child's head should be in a neutral position. Okay. And then we can scope, use the one size blade of the Miller's laryngoscope. Under proper visualization, we can go for the endotracheal intubation.
As you said, you are using a 3.5 size blade, isn't it? So what should be the angle of mouth?
So for a 3.5 size tube, the angle of mouth can be around 10, 3.5 into
maybe
3.
Around 9.5 to 10.5, isn't it? Okay, fine. So you have secured the tube, you have secured the airway. So
after securing the securing the ET tube, we'll have to check for the position of the ET tube, and we can go for a continuous ETCO2 monitoring, so that we'll get an idea about the ventilation of the child, and if at all the child is again going into a cardiac arrest or anything, we'll get a better idea.
Yes, perfect. So you have now completely resuscitated the child, you have secured the airway. Now you have the fascinating part about this resuscitation is you have just reached that pat triangle. You haven't gone into the main survey, isn't it? So there is one more thing, and there is one more thing which is usually when missed is usually if the child has any sort of underlying unknown history of trauma, because we never know what could be the, in fact currently we have controlled and corrected the possible reversible factors which has been like very evident of us. Now if the child continue to have like altered mental status, so definitely then we need to have some sort of thinking process related to some other injury, possibly maybe some sort of head trauma which is related to why the child is continue to have altered mental status. In that situation, definitely CT brain plane is definitely coming to the picture. Now this is where the emergency medicine physician gets the edge. So possibly that needs like around maybe supervision of this patient in the ER maybe for another 6 more hours, because we are expecting the child to recover from the old mental status once the reversible factors have been corrected. Now if the patient is not getting corrected or the child status, the mental status is not getting corrected, so definitely that is where we have to go for a CT brain or imaging of the cranium, because we never know, it could be a maybe a massive traumatic brain injury or something like that, we never know, because child abuse is underlying the whole picture. We are getting covered entirely because definitely the child had an episode of hypoglycemia and severe hypotension because of dehydration. So CT brain plane is definitely coming in the picture if the child continue to have altered mental status.
And as told, like another cause of toxicology also we'll
Yes.
have to roll out.
Yes.
Lactic acidosis, we have a cause of dehydration, but other
Yes.
cause like a toxicological
Analysis has to be done.
also should be
Excellent.
like rolled
Okay,
out.
right. So you have done the resuscitation part, you have intubated the person. How do you manage the post resuscitation in the ER?
So post resuscitation care, we'll have to again start from the airway, breathing, circulation, everything should be like we have to check for. So here whether the ET tube is in situ, whether the child is getting adequate oxygenation, then like all these airway part we have to check for. Then ventilation part also we'll have to check for while connecting the child to the ventilator. If the child is getting adequate tidal volume, is there any like bronchoconstriction or anything, we have to correct all those things. Okay. Then coming to circulation part, if the child's capillary refill time has improved, yes, or if the child is having adequate systolic BP and all, or if not, we'll have to we can again give one more bolus of fluid, like we had given 2 boluses, we can give one more bolus of fluid. If not improving, then we'll have to go for other vasopressor agents. Then coming to disability part, we had already rechecked the GRBS and the 10% dextrose maintenance dose is ongoing. Maintenance dose, it is like for the first 10 kg it is 6 ml per kg, then it is 3 ml per kg for the next 10 kg and 1.5 ml per kg for the remaining
Yes.
weight. And the fluid maintenance fluid is like NS doses 4 ml per kg for the first 10 kg, 2 ml per kg for the next 10 and 1 ml per kg for the remaining.
Kg, isn't it? Okay.
So that part we are going on. Then we can't assess the GCS and all in the immediate post cardiac arrest. Yes. We shouldn't comment on the neuroprognostication or anything, yes, in the first initial few hours of post cardiac arrest. Yes. Then in the disability part, another thing we have to check is the temperature of the child. We have to go for a targeted temperature management. Yes. So here in our setup we can go for cold saline infusions, and we can give cold ice packs in the axilla, groin and all we can place, and we can try to maintain the room temperature in a lower rate if at all possible.
Yes. So 2 things which is more important apart from all these things, now you need to give a different, now you have stabilized the patient in the ER, and now you have to give the opportunity for the other department to come and reassess the patient. Now which all department will you involve in this case?
Since it's a child, we can go for a pediatric intensivist, a pediatric critical care can be involved, and we don't have a definitive cause for this. So we can get a bedside echocardiogram done to rule out any cardiac causes. Then by the time we'll get a detailed history of the patient. So from the history we can know whether, as told, if it is a trauma is there, we can go for a neuroimaging, involve the neurosurgeons. If some other ingestions are there, we can manage it accordingly. So we'll go for a pediatric intensive care.
Yes. So a lot of people may not be agreeing to the way how we manage the child, because see, this is when actually the history part is coming into the picture, because we don't have the time to take an ample history in this case. We manage the child, we come for the correction of all the reversible causes, then we stabilize the person, and then possibly we will take the history. Now, how do you counsel the mother? The mother have come, like almost she had appeared to the ER like maybe 1 hour before itself. You had already told about the child might be requiring maybe like intubation, cardiac arrest, resuscitation. So how do you counsel the mother like from now on? Because now basically you are leaving the patient, you are moving to the next patient probably because you have already stabilized, but then you need to give a small picture of what happened and what is next for the child, isn't it? Otherwise like she will be unable to understand what exactly happened to the child. So how do you counsel the mother?
So one thing is like during the arrest itself, we will have to tell the mother or like the bystanders that the child has gone into a cardiac arrest, because they should be like prognosticated then and there. And after that, we have to explain to them the gravity of the situation, that once the child has gone into cardiac arrest, we are not sure of like how much the neurological outcome will be, or what all the outcome will be. We are not sure of at this point. So we will have to like manage the case. We have to sort out what is the cause. We will have to manage it accordingly, and the duration of the ICU stay required, the duration of the child being in the ventilator, or the child sometimes may end up in a tracheostomy, and all those things we are not sure of at this point. So all these things can happen to the child, should be like explained. And also another thing is it is really traumatic for a mother to accept the current situation. So we can take the help from the medical social worker and or the counselors to give a better counseling to the mother to counsel regarding the state of the child.
Okay. So this ends our discussion about pediatric precardiac arrest and cardiac arrest, and counseling of the parent and involving the other department in multidisciplinary approach. We hope you understood the entire clinical scenario. Thank you for your patient listening.